Thank you so much for being here. Thank you for your patience for working out some of the technical issues at the beginning of today's presentation. I am very excited to be able to introduce our panel today. This is a presentation that will be given by two of our esteemed colleagues here at UMass Chan Medical School. The format today will include presentations from the speakers, followed by a panel discussion with two of their community partners and collaborators. So first, let me introduce the speakers. Melissa Anderson, Dr. Melissa Anderson is a Gallaudet University trained psychologist and clinical researcher who strives to provide accessible behavioral health care to members of the U.S. deaf community. She is an associate professor of psychiatry at UMass Chan Medical School. She founded the DeafYES Center for Deaf Empowerment and Recovery at UMass Chan, where she has continually provided outpatient therapy and conducted research on deaf mental health issues since 2011. We're also pleased to have Dr. Alexander Wilkins here. Dr. Wilkins is an assistant professor at UMass Chan Medical School, where he is also the co-director of the DeafYES Center for Deaf Empowerment and Recovery. He is a recipient of an NIH K23 Career Development Award. His program of research focuses on community-engaged approaches to developing resources for mental health and behavioral health care for deaf and hard of hearing individuals. He also provides outpatient mental health services for deaf and hard of hearing individuals. I realize I just gave the introduction a little bit early. I need to go through some of the logistics today before we get to our speakers. We just wanted to let you know that we ask you to use the Q&A function to ask questions. If you need help through any of, for any technical issues, please chat Donna Raymond. Today's presentation, as you've already guessed, will be given in American Sign Language. It will be translated into English, and we will also have closed captioning available. If you have any issues with those, please let us know. With that, first, I'm going to let you look at these beautiful pictures of Melissa and Alex that I glossed over. And I am very excited to turn it over to both of you to take it away. And just give me a minute to share my screen. Thank you.
This is Melissa. Thank you so much. I will just share my screen here. All right, so I'm hoping everyone can see that clearly. Okay, so hello everyone. My name is Melissa Anderson. This is my sign name. I'm thrilled to be here with my colleagues today.
Hi, I'm Alex Wilkins, and I'm also thrilled to be here with Melissa today.
Today, we are so excited to share with you all what our research team has been working on for the last 10 years. We've not had a specific project that we focused on, but rather a more general or broad discussion about the approach of community engagement in this work. So I'm hoping that you'll find this interesting and edifying, and this will be something that you all can take with you. So we're ready to get started. So today, this is sort of a roadmap of what we'll be discussing. We'll be discussing who the deaf community is in the United States. What are some of the health barriers to healthcare access faced by deaf and hard of hearing communities? How our research team tackled these barriers to try to make it more accessible. The fourth is a fun one. That will be our panel discussion, where we'll have two of our other teammates here from Deaf Community Advisors to join us for a more in-depth discussion. And last, we will wrap up if we have time with some audience question and answer. So anything that you have that you can ask us or ask the panel, we will try to answer those for you. And so that's our general plan for the day. This is important that we disclose some of these disclosures for you. So we have no actual or perceived conflict of interest in relation to this presentation today. We were very fortunate to receive funding through the NIH, the National Institute on alcohol and addiction, and IAAA, alcohol abuse and addiction, as well as the National Institute of Health award number NIDCD, the National Institute of Deafness and Communication Disorders. And the content of this presentation is solely of the presenters and does not necessarily represent the official views of NIH. And I will turn it over to Alex.
This is Alex speaking. Before we delve into our work, we'd like to give you a broad overview of who the deaf community is. We're a very diverse community in the United States, and want to make sure that we're all on the same page. So when we talk about the United States deaf community, we're focusing on about 500,000 plus individuals. We don't have a great estimate of our numbers. People who use American Sign Language as their primary language. They might use other languages as well. But it's people who view their deafness as part of who they are, part of their identity. It's a cultural point of view. It's not so focused on their ears and their speaking and their hearing. It's who they are, identified as deaf people.
In the United States, the deaf community has experienced significant oppression as a population. Most of that oppression has related to linguistic deprivation and prohibiting the use of American Sign Language or depriving individuals of the use of American Sign Language. Most pervasively at the hands of sort of the view of Alexander Graham Bell, which is someone who the general population tends to revere for his contributions, but the deaf community actually views Alexander Graham Bell as an adversary who worked against deaf people's abilities to use American Sign Language and to sign. Alexander Graham Bell originally prohibited sign language from use in many deaf residential schools and successfully closed many deaf residential schools because of his belief that a deaf person and a hearing person meeting in school or marrying and having more deaf children was an undesirable outcome. And so to prevent more deaf children being born, these types of marriages were prohibited and discouraged. And that's really just one example of the type of oppression that deaf people have experienced in the United States historically. And examples like that can really help us to understand why deaf people are resistant to or afraid of or experience distrust, especially in medical research and medical environments.
So with this context, this historical context of deaf people being subjected to this medical view and eugenics, we see that the social determinants of health are really impacted in this community from the communication barriers and discrimination that deaf people have faced. Deaf people often encounter ACEs, right? Adverse childhood experiences, abuse, neglect, very negative experiences, lack of education, lack of access to language, lack of access to information, which all leads to difficulty in employment. They have a hard time finding jobs or maintaining jobs. Educational access is limited and additional discriminations in the world. So we all know that here in the United States, unfortunately, health insurance is connected to employment. So if deaf people are struggling to find a job or can't find work, then their access to the medical access is severely impacted. And that applies to medical and mental health care.
Considering this long history of oppression of the deaf community, as well as what Alex just mentioned, the social determinants of health, it's not a surprise that we see a greater percentage of mental health and addiction issues within the deaf community. For example, mood and anxiety disorders are experienced at about double the rate of the general population. Attempted suicide is experienced 5 times the general population of the general hearing population. Trauma exposure is experienced 2 times more often than in the general population, and problem drinking 3 times more than in the general population. So now we'll discuss what some of the common barriers to healthcare are that were experienced by deaf people. As we described, this population has a high need for services, a significant need for services. At the same time, they're experiencing challenges to accessing services.
This is Alex speaking. The U.S. deaf community often is first recognized by its language. Its primary language is American Sign Language. And unfortunately, we don't have a number of ASL fluent professionals, right, dealing with mental health services in the United States. We just don't have enough people. In addition, I mean, there's more. There's a growing number of, psychologists and therapists, but it's still limited. Secondly, we have a limited access to and willingness to provide interpreters in these settings. Oftentimes, medical staff will say, we can't afford it. We can't provide interpreters. Hearing providers will say, well, we can write back and forth. We can type back and forth. We can give you some captions, which sometimes works, sometimes is okay. But for many deaf people, English is a second language and they're often not very proficient at it. So it doesn't provide equal access to the deaf community. And if you don't have direct communication in a language that's accessible to this population, that's problematic. Plus, this population has endured language deprivation, so they don't even have access to ASL, their first language, oftentimes, or not until later. So many individuals have been impacted gravely by language deprivation. If a child doesn't have access to a first language until after age 3 or age 5, then they're going to suffer downstream cognitive deficits, abstract thinking abilities, theory of mind, communication abilities to just acquire the basic functioning in the world, which is very severe.
This is Melissa. We also see some problems with health literacy within this population. And research has demonstrated that deaf people's health literacy is equivalent to other non-English speaking US immigrants. The third point that many that we want to emphasize as really being part of the problem is that many adults who are born deaf or become deaf early in life don't have exposure to their family medical history because they are not sitting, secondhand hearing their parents have these types of conversations, for example. And so that implicit learning and information is something that's missing.
This is Alex. So again, we have a lot of mistrust by, in terms of from the deaf community, in terms of medical health professionals and researchers. And so given this history, oftentimes deaf people don't trust doctors. They think they want to be, they want to fix them. They want to approach their ears instead of their wholeness as human beings. And we want to, oftentimes deaf people will say, I have a fear of going to the ER. I don't want to go to get services. There's not going to be an interpreter there. And oftentimes somebody will be sent to a psychologist without any, language support, without any interpreters. And they said, it's happened to me before. I'm not going to go unless I absolutely have to.
So now we'll discuss some of the strategies that our team employed to build trust with the deaf community in our operations and in our work. So first I want to show you, this is our mission at DeafYES. Our mission is to partner with the deaf community to develop innovative addiction and mental health resources that are uniquely and expertly tailored to deaf signing people. One of our greatest priorities in our strategy is to think about how our team is composed. So I am a hearing person doing research in the deaf community, and that's particularly important to me because I am a member of the majority oppressive group as a hearing person, which means that I don't expect automatic trust from the community. But I hope that through my work with the deaf and hard of hearing community and with my colleagues who are deaf advisors, I can start to overcome some of those barriers to trust. So I'll explain some of this in more detail. Most, if not all of our projects are emphasizing the importance of deaf co-leaders. I recognize that what Alex recently said about how many deaf people, or there are insufficient signing therapists or professionals, that's a problem that we have in the research world as well. There aren't sufficient deaf scientists, and our goal is to create a pipeline of sorts to support young deaf researchers and support their becoming future independent researchers who can lead in this field. Deaf community advisors are another important part of our team. That's a model that we've used since our inception in all of our studies. Community advising it can be a layperson from the deaf community. It could be someone who's involved in our team. It becomes a part of our team for up to 4 hours a week, coming to the research team meetings and being involved in that way, helping to guide the study methodology, recruitment approaches, interpreting results, disseminating information and results back to the deaf community. These are some of the responsibilities of those community advisors. Rather than this sort of traditional role of simply advising maybe at a board meeting once a month or quarterly providing feedback, we really value the community involvement as a part of our team, really being hands-on in the work. Our hearing team members, this is our third point, hearing team members have to have the right attitude. Many deaf people in this presentation will read that and immediately know what I mean by that. But for anyone in the hearing audience, the right attitude means an open mind, an open heart, humility, and a willingness to listen, a willingness to learn and work collaboratively. I think during the panel discussion, we will learn more about that concept, and we'll delve into that further. Our fourth point, intersectionality. We don't only hire team members who are deaf, but we also have we also emphasize intersectional identities, intersectionality in race, ethnicity, gender, sexual orientation, nationality, age. All of these factors are important to try to pay attention to as we develop our teams. Last but not least, collaboration as a good guiding value. That's how we run our teams. We try to build our teams as best we can, and rather than being hierarchical, sort of a top-down environment, we try to level out that hierarchy and experience like a balanced sharing of power amongst our team in a collaborative way.
This is Alex. So our approach to the research is also holistic. Our research questions and research approach, we're looking at the deaf person holistically, as a whole person. And we want to improve deaf people's access, their quality of life, their quality of services, improve their experiences as a deaf person in the field, in the healthcare field. So access is a key feature of that. We want to, deaf people are really used to accommodating hearing people and, sort of adjusting and adapting to the hearing world and hearing systems. But we want to shift that paradigm and encourage hearing professionals to accommodate deaf clients and deaf patients instead. So that's represented in the community work that we do. We get community input. We are guided by the community members themselves. We ask them, what's important to you? What ideas do you have that we can support? They might have better ideas than the professionals have in terms of guiding their healthcare.
Melissa, do you mind if I just add a quick example to that? So we did a recent project where we worked, initially the goal was to make new training videos to educate hearing researchers about how best to interact with deaf people and deaf community. But after we ran several focus groups, we heard from the deaf community that that really wasn't the priority, that the priority was teaching doctors, nurses, and other healthcare professionals and providers how best to interact with the deaf community. And so with the support of NIH, we were able to redirect that study, that entire project really, and the funding for that project, and base it and accommodate really more the feedback that we received from the deaf community. And so that's just a cool example of being able to accommodate and incorporate feedback from the deaf community.
Alex says, yes, that was a great example. So there's many different ways to collaborate with the community. As we mentioned, we have deaf community advisors, and we also want a lot more input from as many people as possible. So one thing we've done is conduct several different projects, which are focus groups or interviews. So on the bottom left of the screen, we have this, it was pre-COVID, right, where we could all meet in person. And this project that Melissa just mentioned is really about how we can help researchers to work with deaf people. So the original focus group for this project, we got several people who had experience in research. We asked them why they were involved, why not be involved, and so just to sort of, how can we help? At the top right of your screen, you could see an interview, a piece of an interview. So this is a project we're working on in improving the motivational enhancement therapy, MET, for deaf people. So we got people to talk about their experience with recovery. What were the barriers? What would help them be more successful in their recovery journey? What was most important for us to focus on in achieving that aim? So it was a great source, a fund of information for us.
Another approach that we've taken to recruit input from the deaf community has been to host 3 community forums. We had one in fall of 2016, just after establishing our research center. And we realized that a lot of that mistrust was still really at play. They didn't know, the community didn't know who we were. We hadn't really proved ourselves. We hadn't really earned that trust of the community yet. And so we recognized that we needed to start with a very basic foundation and open up a discussion. And so after that, we hosted 3 forums at 3 deaf residential schools, not at the universities, but the forums were spaces that were deaf space, which meant they were signing spaces with maybe a minimal number of hearing representatives. And those were just from the research community. And for those 3 forums, we followed the truth and reconciliation model and let that guide the way that we hosted these forums, where we started with an open conversation about past harms, mistreatment, and the history of mistreatment in this community. We also discussed hearing people's representation in research, and acknowledged and had an institutional apology, recognizing that wrongdoing of the past, and also opening a discussion about how we can collaboratively move forward and improve to make amends for that history of mistreatment. And these were some of the themes that we took away from those forums. So from the 3 forums, we discovered four themes that were discussed. The first was that many deaf people in general didn't feel an ability to trust hearing people. It wasn't specifically aimed toward hearing researchers or doctors, but more just a general mistrust of the hearing community. A second theme we saw was this idea that research in the general public is not for me. It doesn't include me. I see an advertisement, I get an email discussing a research project related to public health, and I think to myself, that doesn't relate to me. They won't provide access, they won't provide interpretation. What is going to be the use of me fighting for that everyday accessibility to be a part of this, and why bother? Third was that often the results of these types of studies, the impacts, are never communicated to the deaf community, the impacts of the studies and the results of the studies. And the fourth was that there was an overall feeling that often hearing researchers come into the deaf community, collect data, and then really sort of take advantage of the community. They benefit from it personally, but never make an effort to give back beyond their initial experiment or their initial data collection. So those were things that came up, and we were discussing how to take the next steps to improve the situation going forward.
This is Alex. One key value that guides our work is transparency. So we want to be very clear about what we're doing and why we're doing it. We talk about our process. We want to be visible in the community. And one way we can do that is through social media. Historically, we used Facebook because we're two older people, Melissa and I, so Facebook is our thing. But
yeah, we're not really hip.
But more recently, we've set up a website, and last summer we talked about our research and our research, processes and engaging more people, and we've posted a lot of our materials that we've developed so that they're accessible and that we can really forward our transparency and get community support and buy-in and input. So this message about why we're doing this research is really important. And we want participants, we want community input. And that's the message we're trying to send over social media and other online methods.
And from those 3 community forums I discussed, we realized that we needed an intentional process of giving back to the community. I can explain some of the examples of how we're approaching that. So where possible, we prioritize hiring deaf community members, staff members, community advisors. For example, our website, we could have hired any random hearing website designer to design our website, but instead we decided to pursue a deaf website designer to work on that for us. Our research videos, where we added captioning, we looked for a deaf-led captioning company rather than a hearing-owned company to, again, try to support the deaf community and the deaf people we're aiming to serve, to make it within our organization as much as possible. Paying participants well. That's not really a novel idea, but making sure that we are compensating participants fairly. Offering free community presentations. Hosting community events, like the picture on the bottom right, that was from the interpreter's just clarifying, sorry. The red carpet event that we hosted, so we can see some of these pictures where we invited deaf community members to come and see the release of these videos. And Alex and I also sort of informally created a counseling network or a therapy referral network where people can ask us for support in referring to trusted community therapists. And last, an important part of our work has been creating open access in all of our media. So on our websites, in the news, as much as possible, we're trying to ensure that there's open access interventions for free.
Another thing, this is Alex, another thing we're doing is focusing on the deaf community while we develop these interventions. So a lot of our work entails filming, right? Because ASL is a visual language and we need to show it show the information visually. So we involve deaf people or ASL proficient people at every stage of the process. The videos we've created so far have used deaf directors. The filmmakers we use are ASL proficient. The script writing process is a collaboration between the filmmakers and the directors and the deaf community advisors, as well as Melissa and I, so that everyone is involved in the process. They can see and make sense of the sign and how that translates to English, how it is very ASL centric. We recruit deaf actors. As you can see in the pictures of this picture from our most recent video, it's a call to deaf actors. We recruit and support deaf actors in this process. It's cool. So a lot of community members are engaged and interested in this process, and it's exciting to see their involvement and to see their investment.
We have some more pictures here. This is Melissa. These are some pictures from that recent filming that Alex was describing. But now we're excited that we'll be able to show you some examples of our work and the end product that we've been able to produce. And hopefully you can see how the community partnership, how the community engagement has really increased the quality of the end product. So this first clip will show an example from a counseling toolkit that was called Signs of Safety. And in the clip, you'll see that the purpose is for deaf people to receive counseling services for trauma experiences. And so I'll just show a brief clip of this. Just so you're aware, this video doesn't have any audio, so you should be able to follow along with the closed captioning. Perfect. So that's just a brief clip from one of the counseling toolkits. The second example, I think we have enough time. Alex, what do you think? Should we go ahead?
Yeah, I think so.
Okay, so our second example is from the community level training intervention.
It's called QPR.
QPR.
Question, persuade, and refer.
And so that intervention is to educate people about how to identify maybe a symptom or an example of a sign that a friend is possibly considering suicide or that someone's considering suicide. and offering mental health focused support. And so this is another deaf-friendly accommodation that the training module will show. And I'll just give you a brief clip here.
It seems to be frozen. Seems Melissa's. Okay, so Melissa has just texted me. I think she's lost connection. So she lost power and she said she'll be back in 1 minute. Okay. Okay, so I'm going to share my screen now. So just give me 1 second. Okay. So now what we'll do is we'll talk about the third example on the video, which is an educational video where we talk about, we basically show a scene of a deafblind individual and his experience in the ER and how we can do better.
Are we just going to make sure the captions? Okay.
Okay, let me go back and start it again. Here we go. Okay.
So it doesn't look like we have sound, but I'm back now. So I can actually share it.
Okay.
Sorry about that. It's an embarrassing time for the power to go out. All right, I think we are fixed now.
The patient's deaf. We call 911 through the texting app. I couldn't ask the appropriate questions in the ambulance, but he's obviously suffering from severe chest pain and he's in distress.
Get bad. He keeps signing stuff. We just don't know what he's saying.
Got it. Thanks, guys. Let's get that interpreter thing.
On it. Where was that video interpreter thing? I thought it lived in this room.
Ultrasound borrowed it yesterday. I guess they never brought it back. Can you tell me what happened? Is there pen and paper around here?
Yep, I got it. Here you go. Oh, found it. Someone left it in the hallway. And we have power. Where's the menu on this thing? Oh, there it is.
Yes, soon. Oh, let's get some pain meds on board, please.
Oh man, this thing is slow.
Hello. Are you prepared to work with a variety of deaf patients?
This is Melissa. Okay, so now I'm stopped sharing. Wait. Okay, sorry for the technical problems. My electricity literally just surged, went off and came back on, and then in the middle of a presentation. But thank you all for your patience. I appreciate that. So now we are ready for the fun part. We have our panel discussion now with two members of our deaf advisors from our community. Reese McGovern and Felicia McGinnis. So I will let them introduce themselves, and then I will start posing some of the questions that we have. So if the audience is able to, and you would like to add any questions, you can please add those to the Q&A, and we can try to ask those of our panelists as well. Reese, would you mind getting us started?
Sure. Do I need to be spotlit? I think please spotlight me.
Okay, great. I will add the spotlight.
Great. All right. Can everyone see me okay? Wonderful. Hello, everybody. My name is Reese. This is my name sign. I'm one of the deaf community advisors for the DeafYES team. And should I summarize my background? I guess to summarize quickly, I'm a teacher. I'm a longtime educator in a speech language program for deaf children and families. I'm hard of hearing myself. I grew up hearing and lost my hearing rather quickly at the age of 7. So I go back and forth between English and ASL, but I prefer ASL. Felicia?
Hi, everyone. My name is Felicia McGinnis. This is my sign name. I am also another of the deaf community advisors for the DeafYES team. A little bit about myself. I used to work in deaf education and became a clinical research coordinator for DeafYES. I also am a graduate student. I just started this year at SUNY Rockport. So I see some of you from the Rochester area. And so I also live in Rochester. And I'm happy to be here today. This is Melissa. And the exciting news is also that Felicia was a deaf community advisor, but now she is a full-time staff member on our research team. So that's something that's very recently happened and we're really excited about. So I will ask the first question. So community engagement in deaf health research, why is that so important? Reese, did you want to start?
Yeah, I think you've laid out so many of the crucial issues around getting deaf community perspectives. I mean, the hearing community at large is in the majority and dominates these systems. And so deaf people don't really trust what's going on in the hearing world because of the abuse and oppression they've encountered with it. So we've often been dismissed in terms of our input, our engagement, our ideas. And I think DeafYES offers a solution to that, to addressing the barriers and to acknowledge what we've seen. We value the deaf experience, and we think it's so important to resolve these historical issues. And we can make adaptations to the system with deaf community input. That's why it's so important.
This is Felicia. I can add as well. I think the deaf population and the community itself is really unique culturally and linguistically. As they both mentioned, research is often doesn't recognize the unique nature of the community. And so it's really important to get a hands-on investigation of the ways that the culture and language are unique and how that plays into the deaf identity.
And if I could add something as well, this is Reese.
Of course.
The deaf community has so much information. There's so much information the deaf community misses out on. So, and we're learning a lot from the research world, and so it's really a two-way street. The research community is learning a lot from us, and we're learning a lot from the research community. So it really is a benefit to both worlds, and works both ways.
That's a great point. It's painful to learn, but that cross training is really, really critical. Alex, did you have the next question?
Yes. Oh, sorry, this is Reese again. I just saw in the chat somebody's leaving, but she just asked a question in the Q&A. So I would love to, and it applies to our discussion right now.
Sure, yeah, go ahead.
So if you would mind for the host allowing the chat, but I looked at the question, and the question asks about Q&A, communication through text. It's in the Q&A. So in emergency situations, is it okay to use text to communicate with deaf people? And I would say, text is great, but I just, want to share with the host, if you could let the audience have access to this. I've texted my partner, right, who is deafblind. We both have appointments at the same time on the same day. So I texted my partner, and they said, well, would English be okay? And really, it doesn't look the same in English as in ASL. The deaf community and deaf culture communicates using ASL, a visual language. Can you share this with the audience? Can you share these? Okay, anyway, thank you. So when you can see from what I've written here, the understanding, right? This is an issue. This is the English that doctors are going to get, right? It's really ASL. ASL is a completely distinct grammar. So when somebody's signing and they think, well, I'll type what I'm signing, it's going to come out looking odd in English because it's not following the grammar of English. And this is what you'll encounter. Would you consider that this is successful? If you're a signer, you can make sense of it. But, GA, what is that? Well, we know in the deaf community, that means go ahead, meaning it's my turn to text back. So these kinds of issues, texting can be good if the deaf person is bilingual in English. But in an emergency situation, when the deaf person is under distress, English is not their first language, it's not going to be the best tool. So you really have to check with the deaf person first before you rely on texting.
That was a great catch, Reese. Thank you for bringing that to our attention. Alex, you can take the next one.
Yeah, Alex says, Reese, thank you for that. So I want to know what your experience with community engaged research has been. And Reese says, I'll allow Felicia to answer that. As a full-time staff now, its importance.
This is Felicia. Yes, so for the last 2 years, December will be 2 years, I've been working on this project called Vital Signs. And as a deaf community advisor involved with this team, I'm providing the perspective of on the research that's been gathered. And there's been a lot of feedback involved in that process. More than I initially expected. I felt more than most, I think more than most people would expect. With human behavior, we know it's very complicated and we need to have sort of a 360-degree view of it to fully understand what's going on. And on top of that, during a research project, when we're doing focus groups or video training, it's wonderful to see who the participants are from the deaf community who are still reaching out to our team after the fact, reaching out to Melissa or Alex and saying that they're looking forward to the next opportunities to collaborate and looking forward to getting more information about that. And that developing that transparency and that collaboration with Melissa and Alex has been fantastic, and it's giving ongoing benefits to us because it makes the whole experience richer. The information that we gather is more profound as well.
This is Reese. I would echo everything that Felicia just said. I mean, from my personal experience and my personal perspective, being a deaf community advisor is, really working on the as a team. And right now we've done this virtually a lot. We've, transitioned this to other types of work where we can really develop new family mentorship programs in my school. Hopefully they'll adopt this in the Commonwealth of Massachusetts. So that's my goal. I feel that my experience in the last 2 years working as a deaf community advisor, I've seen a model for community engagement research. Working with Melissa, working with Alex, I feel that I've learned so much about how we can work in collaboration with teams, with community members, with constituents, and really know what that means, that we welcome the collaboration, that we want the feedback, that we want engagement, that it only betters both communities. And we value the experiences of deaf people and that their experiences is so beneficial to improving the work. It's an honor to have been involved. And it's so exciting to learn and hopefully then disseminate this information through this model to increase our work. I mean, I can't applaud the program enough, to be honest.
This is Melissa. We should just end now with that glowing review. No, thank you so much.
Alex says, I think it's so wonderful that it's not only, through your experience, but this dissemination, this idea that it's a great process. It's a great way to work with people and do this research in a more meaningful and holistic way. So yeah, hopefully it will expand.
This is Melissa. It makes ripples, really. But we'll move on to the third question. When you think about community engagement in your work in general with the hearing population and your collaborative work with deaf people and working with those distinct groups, how is working with the deaf community unique as compared with the general hearing population?
This is Reese. I think access is paramount, right? It's privileged here. So working in collaboration means that the deaf community has access. So we don't really have to consider making accommodations, right? In that sense, it's a given. As disabled people, we are everywhere and we tend to fall through the cracks. So I think with community engagement research, we can think about improving, race access and representation of race and ethnicity and languages and educational levels. All of those things need improvement. but we don't tend to think about access for language and access for disability. So take Spanish language users. They have limited access to public health. The deaf community, having a collaborative research, prioritizes their language, privileges their language in involving them, getting them involved in the system. In general research, we can use deaf research and deaf community engagement into general research. Everyone benefits from access, from having that layer involved. And then people aren't slipping through the cracks and their voices are being heard. And I think it makes a huge difference.
This is Felicia. I'd like to add about the type of research that we've seen historically. There's been a lot of focus on deafness in terms of how to reduce deafness, how to eradicate deafness, how to resolve deafness. And so having a positive psychological frame is really impactful because of we focus on deafness as a gain, deaf gain, the cultural component of deafness. Resiliency when it comes to being a deaf person in a hearing-centric world. And rather than framing that negatively, framing it as a positive to have the deaf identity is really impactful. And when comparing the research with the general population to the research we're discussing here, we've seen there's a lot of mistrust, as we've mentioned. And there's a lot of frameworks in general research that won't apply. As Reese mentioned, things that are written, things that are communicated verbally may not necessarily be applicable, and then people feel that they can't be a part of those. And so research findings through the general population often don't fully reflect the realities of the deaf community. And so that's a huge part of that separation that exists. And research in the general population doesn't always reflect accurately or fully recognize the realities of the deaf community.
Reese says, I would agree with that.
This is Melissa. I'll have you take the next one, Alex.
This is Alex. Our next question is, really applicable to deaf people in research and how that deaf gain is really seen differently from hearing loss. But what would you say, in terms of remote work that we've been doing, what are the challenges and the benefits of conducting deaf community engaged research in this remote world, right? Like Melissa just had her power go out. So that's definitely one challenge. This is Reese. Well, Felicia's just moved, so maybe she can speak to that because remotely works for her, having just moved.
Sure, this is Felicia. Right, technology has really changed everything for our community because it's a small community, but we're really dispersed across the entire country over a large geography. Having an ease of connectivity and ease of connection has been really, really amazing for the deaf community. At the same time, connection with hearing has not necessarily always improved. For example, video phone access through interpreting services, there can be problems for obvious reasons with freezing, as we realize, or different technological issues that interrupt the communication. If we call through a video relay interpreting service, you'll automatically, people sometimes think that it would be an automatically perfect translation, but often there's a lack of information in video remote settings where the interpreters are having a hard time facilitating the communication because of a lack of context. And so using video phones where people aren't necessarily understanding how they're used can be challenging in remote spaces as well.
He says, yeah, I would agree, and also add that this connects back to my comment about texting. When deaf people, FaceTime or whatever with each other, we sign differently, right? We tend to use one hand, we're holding our phone and signing one-handed, and we can make that we can make do, we can understand each other. But during COVID, there became this world of, deaf people using technology and sign, and hearing people, seeing deaf people being engaged over video. Then hearing people got more exposure to deaf ways of signing, because we had already experienced it using VP, video phone, and using FaceTime. So it was a really interesting process to see, hearing people kind of evolve and catch up to the ASL train with the advent of COVID and use of Zoom. But anyway, I would say that, I would add that, VRI, it's okay. I mean, during our work with deaf folks, we see in Amsterdam, in Holland, right? I lived in Amsterdam for a few years, and we didn't have connection, right? Oftentimes we wouldn't, have connection. So if people weren't willing to commit to providing tech support, tech for the meetings, to ensure access through VRI, through, Zoom or what have you, then, that it wouldn't work. But there is a lot of benefit inherent in the technology.
This is Melissa. Yeah, I think we've been lucky in the state and in this country to have a lot of tech evolving, and it's really benefited our team. So the last question is more of an audience question. So what tips do you have for preparing for or starting a new collaboration with a deaf organization? How do you start that new relationship? Do you have any tips on how you might do that?
This is Reese. I think for myself, there's two things that come into play that really make a big impact. One is, make sure that before you even begin the collaboration, make sure that you have a team who is ready with the mindset, the cultural mindset of cultural humility and cultural equity. I mean, just in general, if you're doing community engagement research with any community, you have to be ready to enter that engagement with a cultural humility. Set your egos aside. Don't think that you know everything and that you're coming in to help a community or rescue a community or save a community. Ditch all of that wholesale. Come in with open mind and open heart. Come in ready to listen. Come in with understanding that you have one experience and that the community's experience is equally valuable and one that you need to learn about. You might think, I have more world experience, I have more education, I have, this and that. Don't do that. Come in culturally humble, ready to learn. And that will impact everything in that engagement. Secondly, if you want to partner with the deaf community, you have to first welcome a deaf person, like involve a deaf person first. Figure out the role of deaf people and how you can collaborate with them. Hire deaf people, hire a deaf person first who can share with you how to do this work. There's no replacement for that. You can't think that you can guide this and be a leader for it. You have to take a step back and hire a deaf person to lead it. And that speaks back to the attitude of cultural humility. Deaf community, as a deaf community advisor, you need to you have to involve deaf people first. That's just the model that it has to work that way. And DeafYES has the right model.
This is Felicia. I think it's also important for organizations to really take the time to question the intentions behind their collaborations as well. What is the purpose of it, and how will that collaboration persist long term? And that really opens up to a lot of consideration about trust, and again about the mistrust that the deaf community has in being involved, and the apprehensions that they may have about being involved. So it takes time, and it requires real reflection, true reflection about how to enter the space, and it requires a willingness to learn before entering the space. And the language and the culture, again, of the deaf community is really unique. It's what connects this community, and so having that in mind is essential before, and then having that collaboration is key. Seeing the different perspectives and hearing feedback from different stakeholders in general. We want to be able to collaborate. We just need to, as I said, trust. That trust and that rapport need to be developed. And so putting effort into those things will be the right approach.
Right. Reese is adding, this is not a checklist. This is not like, oh, access, we just checklist, go down the piece of paper and see the 10 things that they need. That's not what this is about. That's not what's effective.
This is Melissa. And I think Felicia also made a great point. The authenticity, the authentic communication it really takes time. It's not something that's going to happen overnight. It's not something that can be rushed. If you have a grant deadline of 4 weeks from now, 4 weeks is not enough time to build that trust and that connection. So really that needs to be happening first. It needs to be done far in advance of any potential research opportunities that may arise. It can't be something that's rushed or pressured. And so it really is a long-term relationship building endeavor.
And this is Reese. And, as we've had, experience with DeafYES virtually, we want to engage with deaf immigrant communities, right? And we're trying to build those relationships now. It's a slow process. And, oftentimes we just don't have enough time to build trust. And that doesn't mean we drop the plan. It means that in light of this, we have to, slow it down and give it the time it needs. But for this project, we can't be rushing, right? You can't rush the development with vital signs of, the development of relationship.
This is Melissa. That's a great point and a great example. So we have a lot of questions that people have submitted into the Q&A. Some of them have been, we've addressed already, but let's take some of those now. So can we think of, one of the questions is, can we think of any examples for how we can balance the traditional research methods and models that are more strictly scientific, balancing that with accommodation of the unique needs of the deaf community? Any thoughts on that? So how do we balance those two sort of opposite poles?
Reese says, I feel like this is a question for you and Alex, Melissa. You're running the show.
This is Melissa. That's fine. I can respond to that briefly with my thoughts. My approach in the beginning of my research and now is quite different, and it's evolved. So in the beginning, I think when I was in an academic community, I had less power, and I was more likely to just sort of accommodate to traditional approaches. But now as our team is growing, I've become more successful. It's become more successful, and I've been able to gain more academic power and sort of fight back more. I think I've been empowered more to give a strong justification for something that needs to be changed and address it more head on. I think recently a grant proposal we submitted included that we proposed that we would be doing things quite differently than sort of the traditional approach, but we justified it with strong justifications from data that we had from recent research, with quotes from deaf people, statistics that we'd acquired, and we included that justification. And I think that over time, building that evidence base is why we can't just adhere to traditional methods is something that's essential here. And innovation is critical for working with this population, and also building the data fund, then the justification of why we need to approach things differently. I hope that answers that question, at least in part. Do we have other thoughts that others want to share?
Reese says, I think you've captured it here. And Alex saying, my experience has been very different. I mean, Melissa started this work at UMass 10 or maybe 11 years ago. And, she had already built upon that form, that framework. She'd gotten that, going. So when I joined, my the research projects were a little bit behind, but working on, we knew what worked and what didn't work in our communities. And I think we were getting a sense of it, but it took a while for the larger community to buy in. And as we gain more evidence, as we can demonstrate the validity, the reliability of this work, and we have steps to follow, we have a very rigorous model, but it's different from the traditional models. It incorporates what one might consider flexibility from those traditional models. But there's different ways to integrate those too. And we just have to be strategic and creative in doing so.
This is Melissa. Is there anything anyone wants to add, or should we go to the next question? All right, so our next question, I think that might be good for this group is, are there any collaborations that you've done so far with deaf elders? And if yes, what have we learned? Reese, do you am I seeing possible desired answer?
This is Reese. I'm thinking about a deaf elder that, we just saw one clip from Vital Signs that incorporated a deaf elder. And I mean, I don't know her age, but she's definitely a senior citizen. And now she's actually close to 90. So this is sort of my first ASL teacher. This is my first ASL teacher. And deaf senior citizens have been involved in our discussions, in our community discussions we've had in our forums. We've had a diverse age range. So it's been very interesting to see her influence. She has, full inclusion in this work. And I think working with a deafblind man who similarly is a senior citizen, they've both, been great to work with, and they're well-respected community members. I think working with them, the experience, it feels as though, well, let me put it this way. We couldn't value them more, their work in the deaf community, their involvement in the deaf community. We see it. We see that deaf seniors have been here, and we want their involvement, and they're excited to be involved too, right? They want to be engaged in this. So I don't think there's anyone I've valued more in this group than their engagement. And we want young people too, but it's all at every age range, hits on important facets of the community.
This is Melissa. Thank you for sharing. Yes, so those are some of the small steps that we've taken to try to engage more with deaf elders, but we're trying to expand on that population even more going forward. And I have a few slides that I want to share just as we wrap up. So if you'd like to learn more about our work and our approach, these are three good places where you can start. These are all references that are available at PubMed for free. You can access those online. And another good place to find information is on our website, which is www.deafyes.org. And you can find information there, updates pertaining to our research projects. You can find some of our training videos and materials. Today, we talked a lot about our newest healthcare provider training videos, and that's something that will be disseminated publicly this December. So we are thrilled to be part of the the APA American Psychological Association's Video Festival this November. And so we will be holding the sharing of that material until some of those materials until the festival. So, but we plan to have that information shared by December, and the videos themselves will become live on our website at that time, on our YouTube and on our website after we've shared them with our participants. So I just want to thank you all now for your attention, for your great questions, your engagement, and I want to thank our panel as well as our interpreters and the school for hosting us.
Yes, Alex says thank you so much, and Reese says thank you.
And this is Stephanie Lemon on behalf of the UMass Center for Clinical and Translational Science. I would love to just want to thank Melissa, Alex, Felicia, and Reese, as well as our interpreters today. This was a truly inspirational and outstanding presentation. You guys just do such amazing work. We're so proud to call you our colleagues. And there were a few unanswered questions in the chat, but we can keep track of those. And if you didn't have your questions answered, we'll direct them to Melissa and Alex and try to get back to you. Thank you so much to everybody for being here. This is definitely one of our presentations where people stayed the longest and where we had people come from all over the country. So it was great to see such a wonderful audience here today. Thank you again to everybody.